Good morning, everybody. I hope you all had a nice weekend. Well, this is our last lecture. What do you guys think? You're surviving. All right, let me just rearrange my screens here. I'm going to go ahead and just call out everybody's name for attendance. If you could please all unmute yourselves for a moment so I can just take attendance that way. Okay, thank you. Cynthia.
Here.
Kenza.
Here.
Esther. I think she
Here.
Okay, there we go. Chelsea.
Here.
All right. Taylor.
Here.
Dominic. Okay. Neil.
Here.
All right. Shay. I know she's just
here. I'm just gonna get the video going soon.
Okay. Stephanie.
Here.
Thank you. Jessica.
Here.
Maya or Mayanley. Okay. Roshan. Gao. Okay. Samantha. Sarah.
Here.
Nicole.
Here.
Thank you. Danielle. Catherine.
Here.
Brittany.
Here.
Haley. Here, Journey. Ashley. Heidi. Paku.
Here.
Thank you. Summer. Thanks.
Here.
Okay, thank you, Summer. Madison. And Lindsay.
Here.
Anybody's name that I didn't call off? No? Okay. All right, you guys. I'm going to go ahead and open up the screen and have you guys write down or type in something from last week that you remember from last week. Okay. So let me do my screen share here. Okay. I think I have to do one more thing. All right, can you guys type on that? Does it show you yet? Soft palate, facial muscle, contraction of the uvula, shortens and broadens, very good. Muscles innervated by, okay, supplied by. Out of my way here a little.
It's not letting you finish writing the sentence.
I was wondering why oh, okay. That's strange. Okay, so the uvula is a paired muscle, very good. It has no insertion. Facial muscle innervation is by cranial nerve 7. And what about the muscles of mastication? Do you guys remember that cranial nerve? What cranial nerve?
Fifth.
The 5th, very good. All right. Okay. And then we have the soft palate has, and I'm not sure who was typing that. What was your
Yeah,
thought?
it was supposed to say the soft palate has 5 paired muscles.
Okay, very good. Contraction of the uvula shortens and broadens. Very good. Uvulas. Pharynx has 3 parts, right? The nasopharynx, the oropharynx, and the laryngopharynx. All right, very good, you guys. Let me stop that and we will get back on. All right, let's see here. And Heidi, if you could turn on your video, and Shay, I know you were working on it. All right, let's go to our PowerPoint. So today we're going to start by talking about the arterial and venous supply and drainage of the head and neck. Slideshow. There we go. And there we go. And try this again. Share screen. Okay, can you all see that? Yeah. All right, so what do you, give me a baseline. What do you guys remember about the arterial supply and venous drainage from your anatomy course?
There's oxygenated blood and deoxygenated blood.
Very good, very good. So the the blood comes into that right atrium, right? The deoxygenated blood comes in from into the right atrium, goes through the tricuspid valve, into the right ventricle, goes out into the lungs. The lungs bring it back into the left ventricle after it's oxygenated, right? So the right side is deoxygenated, the left side is oxygenated. The left then goes into the left atrium through the bicuspid valve into the left ventricle and then to the aorta, where the aorta then splits off for the head and neck area and then goes down through the thoracic area to supply blood to the rest of the body. Okay, does that sound a little bit familiar to you guys? All right. So the arteries are going to be coming off of that left side, right? Because that's our oxygen-rich blood. Then it goes through the arteries into the capillaries. The capillaries is where the gas exchanges and it picks up all of the, I hate to say toxic, but all the toxins, infections, anything like that. And then that links up to the venous system. Now the arteries have a lot more pressure in them, right? And the veins have less. So arteries are going to be thinner than our veins, all right? So just giving you guys kind of a picture of what this all looks like, okay? Before we get started. All right. So, first things first, the student should be able to trace the blood from the time it returns from the vena cava. That's coming into the heart. Again, right atrium, then the tricuspid valve, then the right ventricle, going down into the lungs, coming back oxygenated, left atrium, bicuspid valve, and left ventricle. To trace the blood supply from the heart to all areas of the oral cavity, including the teeth. So that's going to be important, right? And we know that the lymphatic system and the veins and the nervous system all kind of run together. So that's why I put these 3 chapters together, because a lot of the names are the same because they're following the same path, okay? And they're often intertwined. All right, I've already gone through this. Right ventricle pumps into the pulmonary valve. After collecting the oxygen, moves into the left atrium through the pulmonary veins. From the left atrium, passes through the left atrioventricular or bicuspid mitral valve to the left ventricle, and then that pumps it out through the aorta. So from the aorta, blood flows through the thoracic area and the abdomen, and the aorta then ends at the pelvis as a paired common iliac arteries, which then divide into the legs, right? So in our, let me find my annotate here. Okay, well, it's not wanting to do what I want it to do. Okay, so here we go. So the blood is coming from this left ventricle and going up into the aorta. And we're primarily going to be concerned about these 3 branches, okay? Does anybody know what these 3 branches are?
Are they the carotid?
Okay, so we're going to talk about it. Let's get into it. You're mostly right, okay? So, all right. So the internal, external, and common iliac veins bring blood back to the legs, blah, blah, blah. Okay, so that's just talking about the return. All right, so here we are. So here's our aorta right here, right? Now we have this branch here that then branches. Okay, this is our brachiocephalic trunk. And this goes to the right side. So whenever you're looking at a picture in anatomy, it's just opposite of what you are, okay? So this is my right, so that's their left, if I'm going straight across. Does that make sense? Okay, all right. So going to the right side, we have this brachiocephalic trunk that then divides into the right common carotid and the right subclavian. The left side is a little bit different in that it has the left common carotid branches directly off of the aorta. Okay, and so does the left subclavian. So that's why there's 3 of them. The right side, we have a little more real estate here, okay, with the brachiocephalic aorta. All right, and then the left side, they branch directly off. All right, so we have 2 common carotid arteries. We have our right and our left that run on both sides of the neck. They run within the carotid sheath of the internal jugular vein and the vagus nerve. These are found below the sternocleidomastoid muscle. So remember when we all turned and put our neck down and we felt that sternocleidomastoid muscle? They're running right in there, okay? Or right beneath there. Then our common carotid then divides, okay? And we have an internal and an external carotid artery. Now this is where blood flows, and where it returns is a little bit different in this area, okay? So these are the arteries. So the internal artery, think of what needs to be protected most? Does the brain or does the skin of the face need to be protected most?
Brain.
The brain, right? So internal is going to go directly up to the brain. Okay? That's how I try and remember it. I don't know if that's the way we were created or made, but that's how I always think of it. So then our external common carotid is going to be what is going to give us blood supply to most all of the facial features. Okay? So the internal goes to the skull, then branches, supplies the eyes, the brain, and some of the brain coverings. The external artery has many branches in the neck. So our anterior branches are going to be our superior thyroid artery, the lingual artery. What does lingual mean?
Tongue.
Tongue. Very good. So that's going to be important, right? So our lingual artery is from the anterior branch of the external carotid artery. Then our facial artery supplies the submandibular salivary gland. All right. Our medial branches are going to be the ascending pharyngeal arch and the pharyngeal wall and tonsil area. So you think of like tonsil infections, they're going to be traveling through that ascending pharyngeal artery back to the external carotid. All right, our posterior branches. Posterior, we're thinking occipital, right? Anything posterior auricular and the occipital area. So the final branches, the ones that we're going to spend the most time on, the one that we're going to spend the most time on is the maxillary artery. All right, and then our superficial temporal arteries. So let's talk a little bit about our tongue artery, our lingual artery. This comes off the external carotid artery and has 3 branches. We have the dorsal, the deep, and the sublingual artery. All right. They are both, so the dorsal is going to be the deep posterior of the tongue. The deep lingual is going the dorsal lingual is going to be the deep posterior of the tongue. The deep lingual is the deep anterior portion of the tongue. And then the sublingual is going to be our ventral, underneath, right? Ventral surface of the tongue and the floor of the mouth. Okay? So this supplies the tongue and tissues to the floor of the mouth and the oral cavity. The lingual and facial arteries often are going to come off the same external carotid artery branch, and then they split. Okay? So that branch, that little tiny area where they share space is called the lingual facial trunk. Facial arteries, they ascend from, oh, hold on, I gotta let a student in. All right, the facial artery ascends the side of the neck and runs into the submandibular gland, supplying it, and crosses the lower border of the mandible. Okay, so the reason I have this highlighted here is that if you all feel, start at the angle of your mandible and kind of work your way forward, you're gonna feel like a little notch there. Okay, everybody feel that? Does everybody feel that kind of little notch right there? Yeah, that's where your facial artery is crossing, okay? So if there's severe bleeding on the face, that's where you would place pressure, okay, to that facial artery right there. You apply a bunch of pressure right there to stop it from bleeding. So at this point, the artery gives off a submental branch, which runs along the inferior border of the mandible to the chin. So submental, mental meaning underneath the chin, right? After giving off this branch, the facial artery and vein cross the mandible. They travel across the face and end near the inner corner of the eye. Supplies the blood to the skin and muscles of facial expression. So facial artery, skin, and muscles of facial expression. Branches to the maxillary and mandibular lips and to the side of the nose. So if you cut your lip, that is a branch of the facial artery. All right, now let's talk about our maxillary artery. Maxillary usually meaning upper jaw, right? This is a terminal branch of the external carotid artery. So it's its own branch. It's a terminal branch. This diverges from the external carotid at the neck of the condyle on the deep surface. It has approximately 15 branches, this artery does, but we're only going to talk about a few of them. The things you need to know is that this supplies the muscles of mastication, the teeth. So if you start to have an infection in your tooth, this is the artery that is going in there and going to take care of that, okay? The oral and nasal cavities, also the coverings of the brain, and several smaller areas. From the initial branch, it runs forward to the infratemporal fossa, crosses the lateral pterygoid muscle to enter into the pterygopalatine fossa, which we've talked about previously. Then we have an infratemporal fossa branch, and from that infratemporal fossa branch, we have the inferior alveolar, okay? The inferior alveolar, what you're gonna find is that it runs down and enters the foramen of the mandibular foramen and runs through that mandibular canal. Hopefully this is all starting to come together. This is gonna supply a lot of the teeth on the mandible, such as your molars and premolars. And the reason I'm stressing this is because this is going to be similar to that of the nerves, okay? And you need to know nerves really well when you're giving injections. All right, so this also supplies to the temporal area, the masseter muscle, the pterygoid, middle meningeal, and the buccal, which is also runs with a nerve that we're going to be anesthetizing. All right, so as I said, it does run down to enter the mandibular foramen into the mandibular canal, sends off branches to the mandibular teeth, the periodontal ligaments, and the bone. The premolar region sends the mental artery, and this is the same as the nerves. We have a mental artery branch that exits the mandible through that mental foramen. Do you guys remember where that's located? Where was that mental foramen located?
It's on your chin.
It is on your chin. Do you know between what two teeth?
Premolar.
The two premolars, generally between the two premolars. And that's going to play a role when we get into our pain management course, because you have to give an injection right there near that foramen, and you'll end up applying pressure to get the pulp of the teeth. And we're going to talk about that a little bit more in our nerves chapter, okay? So this supplies the mandibular buccal gingiva, so the buccal, not the lingual, and the mucosa from the premolars to the incisors. Supplies the mucosa of the mandibular lip and chin. So here's our other branches here. Our temporal branch, of course, is going to supply the temporal muscle. Mesenteric branch is going to supply the masseter muscle. Pterygoid branches are going to supply our medial and lateral pterygoid muscles, which are right up in here. Remember, those help us open and close. middle meningeal artery is going to be the major supplier to the meninges of the brain. And then our buccal branch is going to supply the mucosa of the cheek and the buccal mucosa and gingiva of maxillary and mandibular posterior teeth. Okay, so in the previous slide, it was supplying the buccal gingiva mucosa from the premolars forward. So what's getting the molar area? That's going to be our buccal branch. Okay. You guys following me? You're so quiet. All right. So then our pterygopalatine fossa branches, we have 5 general directions: backward to the nasal pharynx, down to the palate, medial to the nasal cavity, laterally to the maxillary tuberosity, and forward into the infraorbital area of the face, meaning right in here, right? So descending palatine arteries, we have 2 branches. Do you guys remember those 2 little foramen that we had on the back of the palate? Our greater and lesser palatine foramens. So we have our lesser palatine artery, which is going to supply the soft palate, and then our greater palatine artery, which is going to supply the palatal mucosa and the maxillary lingual gingiva, because everything else was supplied by by other arteries, the buccal area. Okay, so the greater palatine is going to get our maxillary lingual gingiva. All right. So what's going to get our buccal in the maxillary? Well, we have our superior alveolar artery, and that comes out of the pterygopalatine fossa through the pterygomaxillary fissure onto the maxillary tuberosity and enters the bone behind the 3rd molar. This supplies all the maxillary posterior teeth and part of the maxillary sinus, as well as the posterior buccal mucosa of the upper posterior teeth. Okay, so we could have it supplied by the inferior alveolar or the maxillary arteries. Okay, so our pterygopalatine or sphenopalatine artery runs medially through the sphenopalatine foramen into the nasal cavity. This supplies most parts of the nasal cavity, emerges from the incisive foramen as the nasopalatine artery. All right, so now we have our infraorbital artery. And this is the end of the maxillary artery. So from the floor of the orbital cavity, a branch, the anterior superior alveolar artery, runs down into the bone in front of the maxillary sinus. This supplies the maxillary anterior teeth. So anterior alveolar, anterior teeth, okay. The remainder of the infraorbital artery emerges onto the face and supplies the upper lip and its mucosa, the maxillary labial gingiva, lower eyelid, and the sides of the nose. All right, everybody stretch quick. We went through that fast. You guys are tolerant. I was going to tell you guys, unfortunately, they didn't get sterilized in time. The oral surgeon I worked for had saved some teeth for me where nerves were coming out the ends, the foramen of each of the teeth. And there were some with some really long ones. And then also they were taking out an ankylosed. Do you guys remember what ankylosed means? What does it mean?
Fused.
Yeah, so it's fused to the bone, taken out a 3rd molar, and actually part of the floor of the sinus came out with it. So much bone came out with it. So you could see how smooth that was. So he saved them for me, and I was hoping to get them by today, but it just didn't happen. So I'll try and bring those next week. It's kind of cool, but the sinus membrane didn't perforate or anything during it. But think if that patient were to sneeze really hard or something, that could perforate, right? Till that bone fills in. So it was a tricky one, pretty difficult one. So anyway, all right. Now that we've hopefully cleared our heads a little bit, let's go into our venous drainage. So by the end of this chapter, the student should be able to trace the venous drainage from teeth and the oral cavity back to the heart. To define a hematoma, does anybody already know what a hematoma is?
Bruise.
Yeah, it's like a big bruise, right? And then to discuss the possible problems associated with a posterior superior alveolar injection. Okay, so that's a PSA injection, and we're going to talk about that because while venous drainage usually follows the arteries, it's a little bit different in some areas of the head and neck. So jugular veins, our internal jugular vein drains the brain area. It passes out of the skull through the jugular foramen. This also drains much of the area from the front of the ear to the front of the face. So unlike the internal carotid artery, the internal jugular vein is going to grab a few more things. So as it's returning back, it's going to grab the facial artery, everything that's coming from that facial area, the lingual superficial temporal veins. Okay, so it's just going to grab the facial area, any infection, anything like that, and return it. Okay. So the retromandibular vein is formed from the superficial temporal vein and the maxillary vein. It divides into the posterior and anterior. The retromandibular vein connects the internal and external jugular veins. Okay, so it's connecting the two jugular veins. Now, sometimes a branch of the retromandibular vein is missing, which will then affect the size of the jugular veins. Okay. The posterior retromandibular vein joins with the posterior auricular vein to form the external jugular vein. The anterior retromandibular vein then joins with the facial vein to form the common facial vein, which enters the internal jugular vein. Okay, so does that make sense to everybody? When we're talking about arteries, as it's coming to the teeth, it's coming from the external carotid, but when it's coming back, especially that facial vein, when it's coming back, it's coming back to the internal jugular. Okay? Everybody with me? You guys, okay. You guys look tired today. All right. So now our external jugular vein is going to drain parts of the temporal, maxillary, and posterior auricular areas. That's about all you guys need to know about that. It then joins the subclavian vein, joins the internal jugular, forms the brachiocephalic veins. Then it flows into the superior vena cava, going right into that right atrium. So that now you've seen the whole circle, right? We started with the right atrium, and now we're ending with the right atrium. All right, so here's a few things we need to know. That the maxillary, so we have a pterygoid plexus of veins right up here, okay? So right there, hopefully you guys can see that. And the reason that we want to give that a little thought here is because that plexus, as you can see here, it's like a network, right? It looks like a bunch of wires all jumbled together. Because there's so many veins right there, when you're giving an injection up here, you could nick that or even inject into one of those veins, And that could cause a lot of swelling and bruising. I've seen patients come in where their dentist into the endodontist office that I worked at a long time ago, and they would have this massive bruising under their eye and their cheek. And that was because their dentist had hit and injected into that plexus here, the pterygoid plexus of veins. Okay, so you'll get a lot of hemorrhaging in that area. So it's very close to the maxillary tuberosity, a risk of piercing the vein if the needle is at an improper angle during a PSA nerve block. If slow, blood escapes into the tissue, causing a hematoma. Hematoma is swelling and discoloration of the area. So it could be internal or external. All right, you guys, let's just, I just want to share one video with you guys, and then we'll break, okay? Give me just a second here. I accidentally closed my window. Earlier, here we go. Let me know if you can't hear it once it starts playing.
Hey everyone, it's Megan from KenHub.
You hear it?
And in today's tutorial, we will briefly talk about the arteries of the head and neck. In the following image, we can see the right and left common carotid arteries highlighted in green. The left one originates from the arch of the aorta, and the right from the brachiocephalic artery, before they divide to supply the head and neck regions. The common carotid arteries split into two main branches, the internal carotid artery and the external carotid artery. The external carotid artery is the only division of the common carotid that gives branches to the neck region and supplies the external structures of the head and face. It has 8 branches, which can be remembered by the mnemonic some anatomists like freaking out poor medical students. We will work through these arteries in the following slides. The first branch of the external carotid artery is the...
I do need everybody's monitors on, please. If you could please turn your cameras on. You will be marked absent if they aren't on.
Superior thyroid artery, which supplies the superior portion of the thyroid gland, the infrahyoid muscles, and sternocleidomastoid. The superior thyroid artery branches into the superior laryngeal branch and the sternocleidomastoid branch, supplying the larynx and the sternocleidomastoid muscle respectively. The second branch is the ascending pharyngeal artery, which branches off to supply the pharynx, the soft palate, the prevertebral muscles, the middle ear, and the cranial meninges. The lingual artery is the third branch of the external carotid artery, and it runs beneath the hyoglossus muscles as it branches into the deep lingual and sublingual arteries, which supply the intrinsic muscles of the tongue and the floor of the mouth. The fourth...
Just want to point out right here, see these little foramina here? Foramen? Those are your mental foramen. Okay.
The artery is the facial artery, which gives branches to the tonsils, the palate, and the submandibular glands. The occipital artery is the fifth branch of the external carotid artery, and it supplies the posterior region of the scalp. We can see it here highlighted in green. Next we have the posterior auricular artery, which supplies the adjacent musculature, the parotid gland, the facial nerve, also known as cranial nerve 7, the ear, and the scalp. The maxillary artery is the larger of the two terminal branches of the external carotid artery. Its branches supply the external acoustic meatus, the tympanic membrane, the dura mater and the calvaria, the mandible, the gingivae, the teeth, the temporal muscle, the pterygoid muscle, the masseter muscle, and finally the buccinator muscle. The other terminal branch is the superficial temporal artery, which supplies only the temporal region of the scalp, as it is the smaller temporal branch and does not have additional named branches or divisions. The internal carotid artery is the other arterial branch that stems from the common carotid artery. This artery is divided into 7 segments called Boutier's segments, which supply the brain, the eyes, and the forehead. So, the subclavian arteries give rise to the left and right vertebral arteries, which in turn give rise to the basilar artery, which supplies the brain. The thyrocervical trunk also comes from the subclavian arteries and then gives off several branches. These branches include the inferior thyroid artery, the ascending cervical artery, the transverse cervical artery, and the suprascapular artery.
Okay. All right. Why don't we take a 15-minute break, come back at 9:56, okay? right, if you guys can start coming back. Still waiting for a few people here. Come on back to us, everybody. Okay, well, they're coming back. Let's review a few things. Let's see here. Can somebody tell me about the retromandibular vein?
It connects the internal and external jugular veins.
Okay. And so when it's missing, what happens?
Affects the size of the jugular vein.
Yep, very good. Which two arteries often are together and then separate that I talked about? There's a lot of them, but sometimes they can be together, sometimes they can branch separately from the external carotid, but do you guys remember which two of those were that I talked about?
Is it the lesser and greater palatine artery?
No, it's a good guess. The lingual facial trunk is what it's called. So what two arteries is that?
The lingual and facial artery.
Very good. Yep. So the lingual and facial arteries can sometimes branch off that external carotid together at the lingual facial trunk, and then they branch off. It's not always there. Sometimes they can branch off themselves, but more often than not, they branch off together before separating. Okay. Where are we concerned about a hematoma in the maxillary during injections?
In the veins.
Yep. Which plexus is that?
Pterygoid.
The pterygoid plexus. Do you guys remember which injection it is that we could give in that area that would cause this?
Posterior superior alveolar.
Very good. Very good. Okay. Which jugular vein drains most of the facial area?
The internal.
Internal. And which carotid artery supplies to the facial area?
Sorry, what was the question?
Which carotid artery is going to supply to the facial area? The branch is going to come off which carotid artery? Brittany, do you know this one? What are our two carotid arteries on each side?
Is it the external carotid artery?
Very good, Nicole. Yes. So remember, we have our common carotid, and then it branches off into the internal, which goes up to the brain and supplies some of the blood supply to the eyes. And then we have the external, which has 15, or excuse me, that doesn't have 15 branches. That then has branches that go to the face and the jaws and the thyroid. Okay? All right. All right. Let's go back to our PowerPoint here. Okay, so we're going to move on to the nervous system. And like I said, a lot of this is already, you guys already know the names of them because of the arteries. All right, so let's move forward with this. I gotta find my screen here. Oofda, I had a lot of things open. All right. So at the end of this chapter, the student should be able to name the basic components of the nervous system, to describe the general making up of a spinal nerve, to describe how a sensory impulse causes a motor response, to name the 12 cranial nerves and their general function, to describe the components and general function of the autonomic nervous system. Got a couple more here. To name the specific branches of the trigeminal nerve and which areas of the face and teeth and oral cavity each branch supplies, to determine the nerves and the areas involved in general and special sensation of the tongue, and finally to discuss the nerves and pathways involved in the parasympathetic innervation to the major salivary glands. All right, how many of you guys remember much about cranial nerves from your anatomy course? Do you want a review video or not? Thumbs up if you want a review video quick. Thumbs up? Okay. All right, let me show that to you quick.
Check out this juicy beef burger. Doesn't it look delicious? Eating something yummy like this involves a lot of processes. First, you lay your eyes on it. Then you start to smell the crispy bacon, the gooey cheese, and yep, my mouth is watering.
You all see that?
Then you sink your teeth into the bun and taste your first bite of heaven. Before you know it, it's chewed up, swallowed, and beginning to be digested by your stomach. Crucial to every step of this delicious experience is an interesting and complex group of nerves known as the cranial nerves. Stick around to learn about their functions now in our introductory video to the cranial nerves. Before we begin, I'd like to give you a quick overview of what we're going to be talking about in this tutorial. So we have 12 cranial nerves, which are paired structures and part of the peripheral nervous system, or the PNS. All but the 11th cranial nerve originate from the brain and pass through various foramina and fissures in the cranial cavity. This is why they're known as the cranial nerves. In our image, we can see an inferior or ventral view of the brain with the cranial nerves we're going to be talking about in yellow. Cranial nerves may consist of motor fibers, sensory fibers, or both, so today we'll color code our motor fibers blue and our sensory fibers red. The cranial nerves can be identified by their names, as well as by the Roman numerals 1 to 12. And let's run through them quickly now. So we have the olfactory nerve, the optic nerve, the oculomotor nerve, the trochlear nerve, the trigeminal nerve, the abducens nerve, the facial nerve, the vestibulocochlear nerve, the glossopharyngeal nerve, the vagus nerve, the accessory nerve, and finally the hypoglossal nerve. Now in today's tutorial, we're going to be whizzing through all 12 nerves, learning about their basic anatomy and functions. However, if you want to learn the nitty-gritty details about each cranial nerve, don't forget that we have an awesome series of dedicated videos for each of the cranial nerves that you can sink your teeth into. So let's waste no time and get straight into our tour. So the first cranial nerve that we're going to be talking about is the olfactory nerve. This can be abbreviated to CN1. The olfactory nerve carries special sensory fibers for the sense of smell. So of course, this is the nerve that allows you to smell that delicious burger. Be sure to note that sensory nerves transmit information from the periphery to the brain and are therefore known as afferent nerves. Before we move on, I'll give you some basic information relating to the anatomical course of this nerve, which begins with specialized nerve fibers located in the olfactory mucosa. And these fibers enter the cranial cavity by the cribriform plate of the ethmoid bone and arrive at the olfactory bulb, which is the site of origin for the olfactory tract. Nerve impulses then pass through the olfactory striae to the olfactory areas of the brain. The next cranial nerve, which we can see here highlighted in green, is the optic nerve or CN2. The optic nerve carries special sensory fibers for vision, and specifically it transmits visual impulses from the retina of the eye.
So the first two are sensory, right? So the first one is going to help with the sense of smell. And now this one is going to help with the sense of sight, right? So it's important to not just know what they go to, but whether they are sensory or motor.
To the visual cortex of the brain. As for the course of this nerve, it originates from the bipolar neurons of the retina and leaves the bony orbit to enter the cranial cavity via the optic canal. The two optic nerves run posteromedially in the cranial vault, arriving at the optic chiasm, where the optic nerves partially cross. And you should note that when we talk about the optic nerve, we're referring to the part of the optic pathway between the eyeball and the optic chiasm. And if you remember our list, the third cranial nerve is the oculomotor nerve, or CN3. And true to its name, this nerve provides motor innervation to a number of the extraocular muscles of the eye, namely the levator palpebrae superioris muscle, the inferior oblique muscle, the superior rectus muscle, the inferior rectus muscle, and the medial rectus muscle. The levator palpebrae superioris functions to move the upper eyelid, whereas the rest of these muscles are involved in movement of the eye. The oculomotor nerve also provides parasympathetic innervation to the iris sphincter muscle and the ciliary muscle. And the iris sphincter muscle is responsible for constriction of the pupil, and the ciliary muscle changes the shape of the lens of the eye. In this case, remember that the fibers of the oculomotor nerve transmit information from the brain to the periphery and are therefore known as efferent nerves. Unlike the first two cranial nerves, the oculomotor nerve originates from the midbrain, which is the upper part of the brainstem, and it leaves the anterior surface of the midbrain and exits the cranial cavity to enter the bony orbit of the superior orbital fissure. And the fibers of the oculomotor nerve terminate in the extraocular muscles of the eye. Next, we have the trochlear nerve, or CN4. And this cranial nerve provides motor innervation to the superior oblique muscle only, which is an extraocular muscle of the eye. And as you can see in our image, the superior oblique muscle is arranged as a pulley. And the word for pulley in Latin is trochlea, which is where the cranial nerve gets its name. As for its anatomical course, the trochlear nerve originates from the midbrain and exits from the posterior surface of the brainstem. It then passes anteriorly to enter the bony orbit via the superior orbital fissure, terminating in the superior oblique muscle. And note that this is the only cranial nerve that arises from the posterior aspect of the brainstem. So we're going to be a little bit cheeky now and skip the fifth cranial nerve, but don't worry, we're going to be coming back to it. For the moment, we're going to focus on our sixth cranial nerve, which is the abducens nerve, or CN6. So the abducens nerve is also involved with the extraocular muscles of the eye. Specifically, it provides motor innervation to the lateral rectus muscle. And this nerve's name comes from the fact that the muscle it innervates abducts the eyeball, meaning that it draws it away from the midline. The abducens nerve originates from the pons, which is the middle of the brainstem, and it exits the cranial cavity to enter the bony orbit via the superior orbital fissure, as you can see here. And the fibers of the abducens nerve terminate in the lateral rectus muscle. So remember that the ocular motor nerve, the trochlear nerve, and the abducens nerve, that is cranial nerves 3, 4, and 6, are all responsible for the movement of the eye. Okay, so
Your
let's
board
move on
does
to
like
that
you
nerve.
to know that. Do you want me to rewind that just a little bit? Your boards does like you to know that right there. Give you guys a second to write that down. So these all contribute to eye movement. And then remember, CN2 gives you sight. Okay. And this will be posted if you guys don't get it all. The video will be posted.
That is cranial nerves 3, 4, and 6, are all responsible for the movement of the eye. Okay, so let's move on to that nerve that we skipped, which is the trigeminal nerve or cranial nerve 5. So the trigeminal nerve is a mixed nerve, meaning that it carries both sensory and motor information. And to be more specific, the trigeminal nerve is the primary sensory nerve for the face and anterior scalp, and the motor nerve for the muscles of mastication and other small muscles. The term trigeminal comes from the Latin word trigeminus, meaning triplet, which is more than appropriate considering that the sensory root of the trigeminal nerve divides into 3 terminal nerves: the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. The ophthalmic nerve provides sensory innervation to the anterior half of the scalp, the orbital contents, the upper eyelid, the nasal cavity, the dorsum of the nose, and the frontal sinus, to name a few. The maxillary nerve transmits sensory information from the lower eyelid, the side of the nose, the nasal cavity, the nasopharynx, the cheek, the upper lip, and the upper or maxillary teeth. And finally, we have the mandibular nerve, which innervates structures found in the lower region of the face, such as the lower lip, the anterior 2/3 of the tongue, the lower or mandibular teeth, and the mandible. It also supplies the anterior part of the external ear, the temporal region, and part of the external acoustic meatus. Alright, so it's time to talk about the motor root, which we can now see highlighted in green. So this root provides motor innervation to the muscles of mastication, which are the temporalis, the masseter, and the medial and lateral pterygoid muscles.
I just realized I was on mute. So you do need to know that V3, your mandibular branch, is motor innervation. Your boards absolutely wants you to know that. Okay? And that it innervates the muscles of mastication.
So the motor root of the trigeminal nerve allows you to chow down on tasty treats, and it also supplies motor innervation to the mylohyoid, the anterior belly of the digastric, the tensor tympani, and the tensor veli palatini. Let's have a look at the anatomical course of the trigeminal nerve now. So it exits from the anterolateral surface of the pons as a large sensory root and a small motor root, and the sensory root expands into this structure that you can see here, which is the trigeminal ganglion. Arising from the anterior border of the trigeminal ganglion are the 3 terminal divisions of the trigeminal nerve: the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. And the ophthalmic nerve exits the cranial cavity via the superior orbital fissure, while the maxillary nerve exits the skull via the foramen rotundum, and the mandibular nerve exits the cranial cavity via the foramen ovale.
Remember all those? Think that's important? So V2 comes from where? Foramen rotundum, right? And V3 comes out the foramen ovale.
The smaller motor trigeminal root joins the mandibular nerve distal to the trigeminal ganglion, and therefore the mandibular nerve is the only division of the trigeminal nerve that contains a motor component. So next we have the facial nerve, which can be abbreviated to cranial nerve 7, and this cranial nerve is a mixed nerve, and we can see it here highlighted in green. As you can see, it supplies motor innervation to the muscles of facial expression, such as the orbicularis oculi and the zygomaticus major and minor muscles. These muscles contract to make you smile or frown and allow you to express all sorts of emotions from surprise to fear. And the facial nerve also provides motor innervation to the posterior belly of the digastric muscle, as well as the stapedius and the stylohyoid muscles. It also supplies parasympathetic innervation to the submandibular and sublingual salivary glands, the lacrimal glands, and the mucous glands of the nasal and oral cavities. And the parasympathetic fibers stimulate the secretomotor activity of these glands and arise from the intermediate nerve, which is part of the facial nerve. The seventh cranial nerve also carries special sensory fibers from the anterior two-thirds of the tongue to the brain, and finally it transmits sensory information from part of the external acoustic meatus and to the deeper parts of the ear. The anatomical course of this cranial nerve is rather complex and will be covered in more detail in its own tutorial. However, if we look at our image, we can see that the facial nerve leaves the brainstem from the anterior surface of the pons. It then exits the skull via the stylomastoid foramen to innervate the muscles of facial expression.
Here we go. I just want to replay that for you. You need to know how that's coming out of there.
Yeah. The anatomical course of this cranial nerve is rather complex and will be covered in more detail in its own tutorial. However, if we look at our image, we can see that the facial nerve leaves the brainstem from the anterior surface of the pons. It then exits the skull via the stylomastoid foramen to innervate.
Stylomastoid foramen. Everybody got that? It's not generally a board's question, but I'd probably want to know that. Oops, sorry. My daughter's alarm.
It's the muscles of facial expression. Okay, so it's time to talk now about the vestibulocochlear nerve, or CN8. So this nerve carries special sensory fibers for hearing and balance, and can be divided into two components, the cochlear part and the vestibular part. The cochlear part innervates the cochlea and transmits auditory sensory information to the brain, whereas the vestibular part innervates the vestibular system and transmits information about balance to the brain. So let's have a closer look at the anatomy of this cranial nerve. The vestibulocochlear nerve is formed by the union of the vestibular nerve and the cochlear nerve, and it enters the cranial cavity via the internal acoustic meatus and terminates at the lateral surface of the pons. Let's move on to look at the glossopharyngeal nerve, or cranial nerve 9, which is a mixed nerve. This nerve transmits sensory information from the carotid body and sinus, the posterior third of the tongue, the palatine tonsils, the oropharynx, the skin of the external acoustic meatus, and the tympanic membrane. The glossopharyngeal nerve also carries special sensory fibers for taste from the posterior third of the tongue to the brain. And remember that the anterior two-thirds of the tongue is supplied by the facial nerve. Furthermore, it supplies parasympathetic innervation to the parotid salivary gland. Finally, the ninth cranial nerve supplies motor innervation to the stylopharyngeus muscle, which forms part of the pharyngeal musculature. As for the course associated with the glossopharyngeal nerve, it emerges from the anterolateral surface of dula oblongata, which is the lower part of the brainstem, and it exits the cranial cavity via the jugular foramen, and its fibers terminate in the structures that you can see in this image. The next.
Do you guys think that one would be important? Right? The tongue? Okay.
Next cranial nerve that we're going to be talking about is a rather famous one, and that is the vagus nerve. So the vagus nerve is the most widely distributed of all the cranial nerves, and funnily enough, vagus means wandering in Latin. And the vagus nerve is a mixed nerve, meaning that it consists of both motor and sensory nerve fibers. It provides sensory information to various structures, including the heart, the lungs, the palate, the pharynx, the larynx, the trachea, the bronchi, and the external ear. And the vagus nerve also carries special sensory fibers for taste from around the epiglottis and the pharynx to the brain. Furthermore, this nerve supplies parasympathetic innervation to the smooth muscle and glands found in the pharynx, the larynx, the organs of the thorax, and the organs of the foregut and midgut. And remember that parasympathetic innervation generally results in what's commonly known as the rest and digest response, meaning that it does things like slow our heart rate and get our stomach and small intestine busy at digesting our recently inhaled burger. Finally, the 10th cranial nerve provides motor innervation to the palatoglossus, which is a muscle of the tongue, as well as muscles of the soft palate, the pharynx, and the larynx. And in this way, it assists with speech and swallowing. Like the glossopharyngeal nerve, the vagus nerve originates from the medulla oblongata and exits the cranial cavity via the jugular foramen. It has the longest anatomical course of all the cranial nerves and extends from the head all the way to the abdomen. All right, time for our penultimate cranial nerve, which is the accessory nerve, also sometimes referred to as the spinal accessory nerve. So this nerve provides motor innervation to the sternocleidomastoid and the trapezius muscle. As for the course of the accessory nerve, the fibers of the nerve originate from the spinal cord and ascend to enter the cranial cavity via the foramen magnum. The accessory nerve then continues along the cranial vault and exits the cranial cavity through the jugular foramen. And when it exits the jugular foramen, it ascends to the neck to innervate the two muscles we've already mentioned, the sternocleidomastoid and the trapezius. And finally, we're going to talk about the 12th cranial nerve, which is the hypoglossal nerve. As the name suggests, hypo meaning below and glossus meaning tongue, the hypoglossal nerve provides motor innervation to the intrinsic and extrinsic muscles of the tongue, with the exception of the palatoglossus muscle, which is innervated by the vagus nerve. The hypoglossal nerve leaves the anterior surface of the medulla oblongata and exits the cranial cavity via the hypoglossal canal. And as we can see, it then goes on to innervate most of the muscles of the tongue. All right, so it's now that time in the tutorial where I normally talk about some clinical notes relating to the structures that we've learnt about. However, today we're going to do something a little bit different. We're going to be talking about the 13th cranial nerve. Yes, you heard me right. 13th. There's another rather forgotten member to this family. The terminal nerve, also known as cranial nerve 0 or cranial nerve N, is located medial to the olfactory nerve and exits the skull via the cribriform plate. And this nerve appears to exist in all vertebrates, and that includes humans. However, due to its extremely fine and delicate nature, the terminal nerve is often destroyed during the dissection process and has therefore been long overlooked as a cranial nerve. Now, what does this mysterious little nerve do? Well, believe it or not, the terminal nerve is thought to play a role in reproductive behaviours, specifically relating to the reception and recognition of pheromones. You see, pheromones are chemical signals involved in sexual attraction and mate selection, in addition to improved mood and heightened focus of the receiver. They promote synthesis of hormones in our pituitary gland, known as gonadotropins, and this in turn regulates the production and secretion of the sex hormones, testosterone and estrogen. And these hormones ultimately command the sexual behaviours controlling the biology of our reproduction. So your 13th cranial nerve may be key to how you select your romantic partner. To memorize the names and the order of the cranial nerves, try using the mnemonic.
You guys might want to write this down, okay? Maybe you guys already have mnemonics from your anatomy class, but these are very helpful.
On they travelled and found Voldemort guarding very ancient Horcruxes.
Go if any of you want to write that down. There's a couple more I believe they have on here.
The first letter of each word in our mnemonic stands for the first letter of each cranial nerve. So on they travelled and found Voldemort guarding very ancient Horcruxes stands for the olfactory nerve, the optic nerve, the oculomotor nerve, the trochlear nerve, the trigeminal nerve, the abducens nerve, the facial nerve, the vestibulocochlear nerve, the glossopharyngeal nerve, the vagus nerve, the accessory nerve, and the hypoglossal nerve. And that's it. Our cranial nerve mnemonic, on they travelled and found Voldemort guarding very ancient Horcruxes. Now, it's one thing to remember what the names of the cranial nerves are, but how about we take it to the next level? and use another mnemonic to learn whether each cranial nerve is a sensory nerve, a motor nerve, or both. To master this one, listen to a word of advice from our chum Harry. Some say money matters, but my bestie says big broomsticks matter most. Let's quickly fly through this mnemonic. In this mnemonic, S stands for sensory, M stands for motor, and B stands for both. The olfactory and optic nerves are sensory, while the oculomotor and trochlear nerves are motor. The trigeminal is both sensory and motor, while the abducens nerve is only motor. The facial nerve is also both sensory and motor, and the vestibulocochlear nerve is sensory, while the glossopharyngeal and the vagus nerves are both sensory and motor nerves. And the last two nerves, the accessory and the hypoglossal nerves, are motor nerves. Master these two mnemonics, and you're sure to be a cranial nerve wizard in your next anatomy exam.
Okay, did that help you guys? Nice little refresher, hopefully. I love their videos. All right, let's go back to our...
I found this little drawing. That one helped me in anatomy.
Oh, okay.
So
Okay.
that one helped me a lot. So now you can find it on Google too.
Okay, great. So if you guys need an additional resource, there it is. All right, let's go back to our PowerPoint. We can skip over a lot of this, some of this here. So the central nervous system is the brain and the spinal cord. Everything else is the peripheral nervous system. What I want you guys to really pay attention to is the autonomic nervous system, because once we progress on to pharmacology next semester, there's going to be a lot of information on the autonomic nervous system. So just kind of paying attention to what each of those does, okay? Then we have our sympathetic and our parasympathetic. Then we have our somatic, which has our sensory and our motor, okay, where we can tell it what to do. All right, so here's our cranial nerves. So neurons transmit the message in one direction. I think you guys, this should just be a review for you. You can read through it. So central nervous system is the brain and the spinal cord. They contain motor and sensory neurons. Pain is transmitted via a receptor that sends a message to the brain. Okay, so something tells you it hurts, goes to the brain. Is that afferent or efferent, you guys? From the periphery to the brain. Give it a shot, Summer. I know you can. Afferent or efferent? Somebody give it a shot here. Kenza, can you help us out? Afferent. Very good. It's going away from the site to the brain. Okay. Then the brain is going to interpret it, and then it's going to send a motor response back to the site. Okay. And that would be efferent. Okay. So sensory are afferent and motor are efferent. All right. So there is a thing called the reflex arc, and this takes place in the spinal cord between the sensory neuron and the motor neuron. And what this does is that the intercalated neuron carries the message directly from the sensory route to the motor without going to the brain. So it's a shorter connection there to send out a quicker response. Okay, so the shortcut in the nervous system is known as the reflex arc. Okay, so again, this is happening in the spinal cord rather than in the brain. All right, so peripheral nervous system, we have our spinal nerves, our cranial nerves, and our autonomic nervous system. peripheral nervous system, spinal nerves extend from the spinal cord to distant parts of the body. There are 31 pairs. We have 8 cervical, 12 thorax, 5 lumbar, 5 sacral, and 1 coccygeal. They are distributed by region from the neck to the toes. At the point where the dorsal and ventral roots meet is the beginning of the spinal nerve. At this point, the spinal nerve then divides into small dorsal ramus and a larger ventral primary ramus. This division occurs some distance after the roots have left the gray matter of the spinal cord. So what you can't, this is kind of a small picture here that I just added today. Probably isn't on yours, but right here it says posterior ramus. This is our dorsal ramus. So this is a thin, smaller ramus, and then this is going to be our ventral, okay? And this is where the nerves come out of. So our ventrals, our motor, our dorsal is the collection of the sensory. So our sensory is coming in here. You can see that here, coming in the dorsal, leaving out the ventral, okay? And I feel like we can kind of go through this pretty quickly. Motor muscles of mastication, a soft palate muscle. So the tensor valley, palatine, and tensor tympani muscles of the ear also. All right, we went through that in the video. All right, so our autonomic nervous system is automatic, okay? It's not willfully controlled, contains motor and sensory fibers. Our motor fibers are gonna supply the smooth cardiac muscles and the glands. So when you see something and you start to salivate, that's not in your control, right? So again, sensory and motor. Our sensory fibers carry visceral sensation from various viscera or organs and mucous membranes from the tonsils down through the digestive and respiratory tract. So there's 2 parts innervating the body. We have our sympathetic and our parasympathetic, and then we have antagonists, which have the opposite actions. Parasympathetic fibers are going to come off the brain with the nerves 3, 7, 9, and 10, and off the spinal cord and the sacral levels, S2 to S4. So we have our cranial and then our sacral levels. And again, this is going to become important next semester. The sympathetic system comes off the spinal cord at the 12 thoracic levels, T1 to T12, and the first 2 lumbar levels. So there are 2 neuron pathways. We have our preganglionic neuron in the central nervous system and the postganglionic neuron in the peripheral system. So once it comes out of the central nervous system, it's preganglionic, and then once it's leaving the peripheral nervous system, it's the postganglionic. Action of the parasympathetic system is confined to the visceral organs. Trigeminal nerve branches, we have, remember this is cranial nerve 5. We have our ophthalmic, which is V1, maxillary V2, mandibular V3. V1 and 2 are sensory only, okay? So you can't make your maxilla move, okay? They innervate the skin of the anterior face and head region. So when we look at our ophthalmic division, there are 3 branches of that also. We have the frontal nerve, which is the supraorbital, supplies the skin above the eye and up into the forehead. Then we have our supratrochlear nerve, which supplies skin of the upper medial corner of the eye. Our lacrimal, which carries sensory response from the skin above the lateral eye area and the lacrimal gland. And then we have a nasociliary, which is the ethmoidal nerve branches that are going into the nasal cavity. Our infratrochlear nerve does go into the inferior medial corner of the eye. All right, so V2, this is a big one for you guys, okay? As hygienists, this is gonna be very important to know. So it branches to the upper teeth. So when you have a toothache, it's V2, if it's on the top, all right? The oral cavity, the nasal cavity, skin of the cheek, midface, and temporal region. Again, the supraperiosteal injections are dependent on how long the roots are, okay? So supraperiosteal injection is one that you give just to get one tooth numb, okay? So you can see in this picture, here, if these roots were even longer, you would have to insert the needle farther. So it is important to look at x-rays, to look at radiographs before you give an injection. So you can estimate about how far up you need to go. And this is infiltration anesthesia when you're just getting one area numb. All right. Continuing with the maxillary division, it has the same name and pathways as the arterial supply to that area. So we have our posterior superior alveolar, our middle superior alveolar, and our anterior superior alveolar. Divides into the posterior superior alveolar nerve, supplies the maxillary buccal gingiva of the premolars and molars. This is our superior alveolar nerve. Enters the bone to supply the second and third maxillary molars and distal buccal and lingual roots of the first maxillary molar. This also supplies part of the maxillary sinus. All right. Now, if we go to our, well, we'll talk about this one in a little bit. All right. Then we have our sphenopalatine nerve, and that supplies the lateral walls of the nasal cavity. Not going to focus too much on that, but this pterygopalatine nerves connect the pterygopalatine ganglion with the maxillary nerve. Descending palatine nerve does separate into two branches. Again, we have our greater palatine and our lesser palatine, right? Our lesser palatine going to supply the soft palate. Our greater palatine is going to provide the innervation of the hard palate that's not innervated by the nasopalatine branch. So our nasopalatine is going to get from canine to canine that hard tissue. Our greater palatine is going to get the posterior, the premolars and molars of the rest of the teeth. Then we have our zygomatic nerve, and that supplies the skin over the cheek and the temple. Of course, zygomatic, we know where that's at, right? All right, then we have our infraorbital nerve, and that supplies skin of the nose, the lower eyelid, skin and mucosa of the upper lip, and maxillary labial gingiva. So our superior alveolar got the labial or buccal gingiva of the premolars and molars, and now we have our infraorbital getting that of the anterior teeth, okay? This sends two branches to supply the rest of the maxillary teeth. So we have our middle superior alveolar, which supplies the premolars, the mesiobuccal root of the maxillary first molars, and part of the maxillary sinus. Then we have our anterior superior alveolar, and that's going to be our anterior teeth. So let me go back a little bit here. So this middle branch can be on its own, but often branches off this here, which is our infraorbital, okay? Now our infraorbital, you can see, innervates the anterior teeth. And if it branches off here, then we're going to see it also doing our premolars, okay? So I want you guys to write this down because this is something that you need to know for pain management. The middle superior alveolar, you can abbreviate it as MSA, is going to anesthetize the pulp, buccal bone, and periosteum of the premolars and the mesial buccal root of the first molar. Okay.
Can you repeat what it anesthetize?
It anesthetizes the pulp, buccal bone, and periosteum of the two premolars and the mesial buccal root of the maxillary first molar. And remember, our PSA, our posterior superior alveolar, is going to get the second and third molars, and then our distal buccal root and our palatal root of the first molar. So the first molar is innervated by two different areas. Okay? Don't blame me. I didn't write the manual on human beings, okay? All right, trigeminal nerve, maxillary division V2, our sphenopalatine supplies lateral, oh, we already went through this. I just went back on that. So both of those branch off of the infraorbital, both the ASA and the MSA. All right. Here's our muscles of mastication. Our trigeminal nerve breaks off into anterior and posterior divisions. Anterior breaks off into 5 nerves, 4 muscles of mastication, 2 nerves to the temporal muscle, and 1 to each masseter muscle, and medial and lateral pterygoids. The last branch of anterior is the buccal nerve. Now your buccal nerve is going to get the buccal tissues of the mandibular molars. Okay, all teeth up to that mental foramen. Then we have our lingual nerve, and when you're giving an injection, you're going into the inferior alveolar, and then you're coming out a little bit. So this lies parallel to the inferior alveolar, which is what we're going to talk about next. This supplies sensation to the floor of the mouth, the lingual mandibular gingiva, and the anterior 2/3 of the tongue. So when we give this injection, it's going to anesthetize the floor of the mouth, the lingual mandibular gingiva, and the anterior 2/3 of the tongue. Does somebody have a question here? Oh. Yes, go ahead, Taylor. Where are you at, Taylor? Okay. All right. Chorda tympani is a branch from the 7th cranial nerve. I'm not sure how that got in the middle here, but okay. Here's our inferior alveolar nerve. This is our most common mandibular nerve block. So it's important that you guys understand this nerve because you'll be giving this injection a lot. Okay. This is going to supply innervation to all of the lower teeth in that quadrant. Okay, remember our quadrants? So from the 3rd molar to the central incisor, it's going to get all those teeth and their periodontal ligaments numb. The mylohyoid nerve branches, supplies the mylohyoid muscle and anterior belly of the digastric. And then the mental nerve branch, which is branching off of this inferior alveolar nerve, supplies the mucosa of the lip, the labial gingiva, in the anterior part of the mandible, and the skin of the lower lip and chin. So the mental nerve is going to get the more anterior part. The buccal is going to get the posterior gingival tissues. So to anesthetize this, the incisive nerve, which is a branch of the inferior alveolar, branches the mental and the incisive. The incisive is going to be the continuation where it gets the pulp of the anterior teeth, and the mental gets the soft tissues outside. So what you have to do when you give an injection there is you actually have to press the drug into that canal. Okay, so you need to put pressure there after you give the anesthetic to get the incisive. Okay, so to get the incisive nerve numb, just the incisive, you're going to give it in that mental area, and then you're going to push it and massage it into that foramen. All right. The auriculotemporal nerve originates from the posterior part of the mandibular nerve. Two roots of this nerve converge into single nerve. Supplies the external acoustic meatus, external part of the tympanic membrane, and temporal skin. The reason we talk about this is because we do give an injection called the Gauge-Gates, which gets all of V3, including the auriculotemporal nerve, anesthetized. All right, let's clear the fog here for a second and switch to cranial nerve 7. So we're going to close the box on cranial nerve 5. Is there any questions regarding cranial nerve 5? A lot of information with it, but super important that you know it. All right, the facial nerve 7, we have our temporal, zygomatic, one or more buccal, and the mandibular and cervical. The cervical branch supplies the platysma muscle. Do you guys remember that from last week? It branches, a branch that goes to the skin behind the ear, the auricular muscles, the stylohyoid muscle, and the posterior digastric muscles. Branch extends through the middle ear and out of the skull as the chorda tympani, which we talked about, and the fibers run in the same bundle with the lingual nerve. Glossopharyngeal nerve sends one branch to the stylopharyngeus. I don't feel like you guys, I feel like the video kind of covered this pretty well. The vagus is a tricky one because something happens with that. You're going to see a lot of heart problems, breathing problems, urinating. We had a friend who had like pinched it or something. I don't know how you pinch a cranial nerve, but thought he was dying because of all of these signs. All right. All right, you guys, let's take a 10-minute break, and this will be a short little chapter, okay? Come back at 11. Excuse me. Okay, everybody, if you could come back. While we're coming back, I will ask a few questions of you guys. Which artery supplies blood supply to the soft palate? Do you guys remember?
The lesser palatine artery.
Right, very good. And the greater palatine is going to give it to the hard palate, that and the nasal palatine, right? Very good, very good. Which cranial nerve supplies eyesight?
Second.
Very good, both of you are right. Yes, the second optic, okay. Let's see here. The tensor motor supply to the tensor veli palatini comes from which cranial nerve?
Trigeminal.
Very good. All right. And where do the intercalated neurons, let's see here. I'm kind of giving that away. Okay. When a neuron runs just between two neurons and doesn't go to the brain, it is a, I just said it.
Intercalated.
There we go. Okay. Which injection, let's see here. Which injection do we have to apply pressure to push the anesthetic through?
Incisive.
The incisive, right. So it's the same as the mental, it's the same injection, but to get the incisive, you have to put pressure on, okay? Let me think of another one. Which nerve supplies or innervates the buccal tissue of the mandibular posterior molars?
Middle superior elevator nerve.
The mandibular posterior molars. The buccal tissue of the mandibular posterior molars.
The posterior superior elevator nerve artery, sorry.
So the superior, so we have middle, anterior, posterior, and middle superior alveolar nerves. Those are all maxillary. Those are all part of V2, okay? So when we're talking about the mandibular, it's actually going to be, and thank you, Kenza, for trying, the mandibular is going to be the buccal injection. That buccal nerve is what supplies, innervates the buccal tissues of the molars and premolars up to the foramen, the mental foramen, okay? And when we're giving a supraperiosteal injection, that's one that just gets a single tooth numb, also called infiltration. What is important for the clinician to know? Why do we have to look at the radiographs? What's that?
How long the roots are.
Correct. How long the roots are. Very good, you guys. Sounds like you guys are getting what we need or finding the resources to get what we need. Okay. let's go back to our lymphoid system. All right, here we go. I hope you all went and got some coffee. Everybody looks tired. I'm tired. Monday morning. All right, the lymphatics and spread of dental infections. This is one of my favorite weeks. I love teaching about the nerves and arteries and the lymph system. I find the human body to be absolutely amazing. All right, so our objectives for this is that you should be able to discuss the function of the lymphatic system, to diagram and label major groups of lymph nodes that drain the teeth and the oral cavity. Now, when you're doing an intra and extra oral exam, we expect you to name which lymph nodes you're feeling. Okay, so you do need to know this for clinical reasons. That way, if you do feel a lymph node and you say, okay, monitor that lymph node, and you refer them to their physician, you say, if it doesn't go away in 2 weeks, go ahead and see your physician. You need to be able to write down where you felt that, which group you felt that on, okay? Third is to define the terms primary, secondary, and tertiary nodes of involvement as they relate to lymph drainage. To name the primary lymph drainage of all teeth. To discuss briefly the concept of fascial space infection, which can be very dangerous. To explain how a fascial space infection may spread from the oral cavity to the thorax. And to define Ludwig's angina. And your boards wants you to know about Ludwig's angina because people can die from that, okay? So let's get started. So the lymphatic system is a component of the immune system. Can you guys tell me what you know so far about the lymphatic system? What organs are involved? You guys want me to play a video to review a little bit? Yep, okay, the tonsils, the spleen, right? Maybe sounding familiar? We'll watch a video at the end. All right, accumulation of tiny channels or tubes with small nodular structures are called lymph nodes, and they're interconnecting them, okay? So these nodes here are all intertwined, okay? The system functions as returning fluids to the bloodstream from various tissues of the body. A filtrate of blood plasma flows out of the capillaries into the surrounding tissues where it becomes extracellular fluid. It's then picked up by the lymphatic vessels or tubules known as the lymphatic fluid. This flows through the tubes into the lymph nodes and leaves the nodes and empties into the venous system and then travels back to the heart. Lymph nodes, they filters for the fluids. Lymphocytes produced within the lymph nodes combat infections. Okay, so our lymphocytes are in our lymph nodes. Most tissues, including the pulp of teeth, have lymph vessels. So yes, your teeth have lymph, okay? So there are 5 superficial groups of lymph nodes in the head and neck. We have our occipital, our mastoid. Okay, so our occipital is behind the ears and drains the crown of the head and may drain into the deeper nodes. The mastoid is behind the ear and drains to the posterior side of the scalp. We have our preauricular and parotid node, and those drain from the anterior head above the eyes. And then the submandibular nodes are right down here. There's a few of them right under here. I have a swollen one here. And they drain the gingiva, teeth, and the tongue. So where is cancer, oral cancer most commonly found? It is found usually on the tongue, although we're starting to see more in the tonsil areas with HPV. So you would find them right here, okay? And then if a patient says, oh yeah, that's tender there, or you feel something hard there, you want to pay special close attention to the chin, the gingiva, the teeth, and the tongue, okay? Then we have our submental nodes, which are under the chin, and they're going to drain the inferior chin, floor of the mouth, tongue tip, and lower incisors. Okay, so the mandibular incisors drain into the submental nodes, which that's the primary site. So where they drain into is considered the primary site. Then there's a sequence of infection as it gets worse, or disease. As it gets worse, it's going to infect secondary sites, just like cancer, right? All right, so here's a nice, you guys might want to put this aside for your preclinical course so you can really understand where all of these are. You could probably take off the wording here if you downloaded this. Take off the wording and have that. All right, so we have our jugulodigastric node, and this is a large node at the angle of the mandible. And this receives drainage from the nodes that drain the anterior ear, the anterolateral scalp, upper face, gingiva, eyelids, and cheeks. Okay. Our submental node, this is found beneath the chin, and it drains into the submandibular node or directly into the lower deep cervical. Depends on which way you're innervated. Okay. But generally submental, submandibular, and then we go into our deep cervical nodes. Okay, so again, you might want to click on this, make it bigger so that you can understand the mapping of infections. All right, then our submandibular nodes near the submandibular gland, so often gets confused with the gland being swollen. So areas that drain into these nodes are the maxillary teeth, except for the third molar, the maxillary sinus, the mandibular canines, and all the mandibular posterior teeth. Because remember, those incisors are draining into the submental. So the only exceptions that don't go into the submandibular, don't drain into submandibular nodes directly, are the maxillary third molars and the mandibular incisors. All right, most of the tongue, cheek area, hard palate, anterior nasal cavity, and submental nodes. Then we have our upper deep, and they are located on the lateral surface of the internal jugular vein. Remember, that's where the facial arteries or veins drain, right? Other nodes drain into this group are the submandibular nodes. So if you have an infection in your incisor, mandibular incisor, the primary site would be the submental. The secondary site, most often, would be the submandibular. The tertiary site would be the upper deep cervical. Is this kind of looking like a little bit of a map for you guys? Okay. So other things that drain into this, the parotid nodes, the parotid gland, and others. So this is the upper deep cervical. The third molar region, the base of the tongue, tonsillar areas, and soft palate, posterior nasal cavity also drain there. So when we're looking at teeth alone, Sarah, where do our incisors, our mandibular incisors drain?
I'm not sure.
Okay, Brittany, do you remember? Which nodes?
I'm not sure also.
Neil? I just said this like 3 times, guys. Where do our incisors? Our mandibular incisors?
Submandibular?
Nope. Nicole?
Is it the chin? Like the chin, the floor of the chin?
So what are those?
The submental nodes?
Submental. So our incisors drain to the submental. Okay. Lindsay, where do all the other teeth drain to except for the maxillary third molars?
The submandibular nodes.
Very good. And then Stephanie, where do the third molars, the maxillary third molars drain?
My mute button doesn't work. The upper
Upper deep cervical. Very good. Very good, you guys. Okay, so incisors, mandibular incisors, submental. Everything else except for the maxillary thirds are going to drain into the submandibular. This is important because we're constantly dealing with tooth infections, you guys. So it's important that you know when you see an abscess here and you feel a swollen lymph node here, you know it's gone to a second site. And this is then becoming a little more serious. Okay. All right, then our lower deep cervical nodes are found on the lateral surface of the internal jugular vein beneath the anterior border of the sternocleidomastoid, so anterior border of the sternocleidomastoid. They drain the upper deep cervical nodes and many of the nodes of the back of the neck, the occipital nodes and some glands. So if you feel a swollen node here, and then you feel a swollen node here, that's a concern, right? That means that it's draining down to there. I actually, had a patient where we felt that, and it was, I think I've told you guys that we just found this out a month or 2 ago, that we felt a node here, he had brain cancer. Okay, so it's so important that you guys check these things for the health of your patient. All right. So the terms primary, secondary, and tertiary nodes are used in discussions about infections and cancer, both of which spread through the lymphatic channels. So you want to refer to the groups of nodes that are affected in a disease process, be able to identify them. If an infection is not stopped by the primary group, it's going to spread to the secondary. And if it doesn't stop there, it's going to go to the tertiary. Okay. So any one of those groups can stop it. So node groups affected by disease, each group of nodes acts as a barrier. The nodes slow the spread. If cancer is detected earlier, it's easier to treat. Once infection or cancer reaches the lower deep cervical nodes and passes through them, it enters the bloodstream, moving directly to the heart and then throughout the body. So that's metastasized if it's cancer, right? Explains why the place of the initial incident of cancer matters. The more nodes it has to pass through, the greater opportunity to slow the spread. All right, let's talk a little bit about fascial spaces. Fascial spaces are spaces between the muscle and the tissue layers. Infection can spread through fascial spaces. They're actually considering making these an organ in and of themselves. It's been a big discussion recently in the biology and anatomy world. This kind of infection follows certain predictable pathways depending on its location. Most dental infections start at the apex of a tooth or in the periodontal space around the tooth. Most periodontal space infections cause swellings of the gingiva or the mucosal tissue. The tooth apex infections cause swellings in the buccal or lingual direction, mainly the buccal. Most buccal swellings can also lead to a gum boil, and this is a swelling in the vestibule area or vestibular area. Infection may then break through the mucosa and drain into the oral cavity. That is called a fistula. Just this thin fibrous tube that your body creates to drain it. It's kind of, that infection is finding the path of least resistance to drain that tooth. Lingual infection will travel to the myohyoid muscle in the floor of the mouth or the tissue behind the chin. All right, so this is Ludwig's angina. Molar infections tend to spread to the submental space, okay? Not the nodes, the space. Will cause Ludwig's angina, which is a swelling beneath the chin in the submental fascial space. Premolar or anterior tooth infections tend to spread to the floor of the mouth and the sublingual space, so it's not as serious. So this can obstruct a patient's airway and lead to death. So this is, many people still die from these infections because they don't have access to care or whatever. But this is managed usually in a clinical setting. Aggressive surgical management, antibiotics, these drains are placed to keep the infection from closing the airway. And I have seen this a couple times, unfortunately. All right, eventually the infection spreads to the lateral pharyngeal and parapharyngeal space on the side of the neck. It may spread around the pharynx to the retropharyngeal space, and from there to the posterior mediastinum in the back of the chest or thoracic cavity. At this point, it becomes fatal. Okay. Maxillary infections. The maxillary infections react slightly differently if the infection does not open into the maxillary buccal vestibule or the palate. It may spread towards the nasal cavity, which is pretty rare. The maxillary sinus, it says rare, but I would say more common than the nasal cavity. But most commonly to the soft tissues of the cheek or below the eye. So you might see somebody who looks like they have a swollen eye when it's actually a dental infection. Okay. All right, any questions regarding the lymph system? Okay, so what is Ludwig's angina, Kate?
Isn't that the swelling right here?
Yep, but where is the anatomical swelling? Like where specifically is it? And anybody can help her out, please.
The submental space?
The submental fascia space. Yep. Now there's a difference between the submental and the sublingual when it comes to this. Submental is going to be a little bit deeper, a little further down. Okay. Let's see here.
So, question: does that look like mumps, like when you get?
No, because it's more down here. Mumps is going to be more here.
Okay, they saw a kid like it was inflamed here, and I didn't know.
Oh yeah, oh yeah. But
So
but
was
there's
that
going to involve more. It's going to involve the cheeks also because it's the parotid gland
Okay.
that gets affected. Where this is more just under the chin.
Okay. Okay.
Okay, good question. All right. Any other questions regarding that? Next week's test is your last one. I'm going to try and put together a game or something for us to play for a quick review of the course. Let's see here. I'll pull up the quiz here. All right, we have 1, 2, 3, 4, 5, 7, 8, 9. So 21 true and false questions. The rest are multiple choice. There are 29 questions. Okay. What else can I give you guys here? The autonomic nervous system is composed of what kind of neurons? There's some that are in the spinal cord, and then it goes out into the periphery. The ones in the spinal cord are
Are they accessory, the ones in the spinal cord?
they are preganglionic. Thank you for trying, Nicole. I always appreciate it. Preganglionic and postganglionic. Remember that? Pre is the spinal cord, and then out into the periphery is going to be our postganglionic. What supplies nerve to the maxillary lingual gingiva?
Is it the greater palatine?
Greater palatine is one. Looking for 3 answers here.
Can you repeat the question?
Which nerve supply or innervate the maxillary lingual tissues? So greater palatine was one.
The lesser palatine,
Lesser palatine, very good. And what about our,
incisive.
not the incisive, your incisive is on the mandibular.
Is it posterior? Superior alveolar?
Nope, that gets the buccal areas. Gets from canine to canine. Was just briefly mentioned. I'm just going to give it to you guys because it's a little tricky. It is the nasopalatine, okay? And that gets from canine to canine on the lingual. Okay. So Esther, you're probably thinking of the incisive papilla, which is where we inject into and covers the nasopalatine foramen, but the incisive nerve is actually on the mandible. So it is a little tricky there, okay? So we know that the molars can drain into the submental space. Where do the mandibular premolars and anterior teeth drain to when we're looking at fascial spaces?
The sublingual.
Sublingual, very good, very good. And Ludwig's angina is due to infections in which of those two spaces?
The submental.
Very good, very good. All right, last one here. Actually, I'm gonna do two on injections. And there is a chapter on injections if you guys feel like you struggle with the nerves and what injections go where. But the, what is the most common? Remember I talked about what the most common mandibular injection is?
Inferior alveolar nerve.
Inferior alveolar, yep. So remember the maxillary are the superior alveolar, mandibular is the inferior alveolar, okay? And then infiltration gets what when we're injecting anesthesia? Infiltration.
Like each nerve branding.
Yeah, so it's going to get, so the supraperiosteal, unfortunately, people often do refer to that as infiltration, but infiltration actually is only in the gingiva. Okay, so it only anesthetizes the gingiva. It's just those very nerve endings, where supraperiosteal would get the tooth, periodontium, and gingiva. Okay, so infiltration means just the gingiva in that area. You would inject just right into that gingiva. Okay. And sometimes people do that to help control bleeding. If you have a lot of bleeding during scaling and root planing in an area, that might be something that you want to do. All right, you guys. Thus completes the lecture portion of this course. Congratulations. You all stayed awake today, from what I can see. And you guys are wrapping this course up. Way to go. This is a tough one. So a lot of information in one course. So you guys are doing really wonderful. I know it's a lot. So, all right. You guys have a fantastic week, and I will see you guys next Monday morning, 9 o'clock for a test, okay? Anybody planning on coming to remediation? Or Chelsea? Okay. All right, go ahead and sign into the link for remediation, okay?